Morning, Mr. Walker, Dr. Cheek.
Good morning, Dr. Curran. How are you?
I guess I should say good
Morning.
good afternoon.
Well,
I'm doing fine.
great. Hmm. Well, it's 1 o'clock here. Okay.
Looks like we already have
A quorum.
we have a quorum already. Is Dr. Toomey there? I see Commissioner's office, but there's the conference room.
Yes, good afternoon, good afternoon. This is the Commissioner's Conference Room. We are waiting on Dr. Toomey to come in. She'll be here in just a second, and we'll be able to get started.
Sounds great.
Shouldn't be too long. Everybody had a good weekend?
Yeah.
Sure did.
Now, we have some new people. It looks like to me. We could introduce ourselves a little more formally during the roll call. Mr. Walker, what do you think?
Well, that's fine. You let me know when you're ready to go, and I will begin.
We'll wait till Dr. Toomey arrives.
Okay.
Dr. Mercer, good afternoon.
Good afternoon. Good afternoon.
Hi, Mike. Mike's hot. Camera on?
Yeah.
Okay. We outside.
Thanks, Rick.
Hi, everyone. Hello, board members and Mr. Chairman or Dr. Chairman and the rest of the board members. Welcome.
Hello, Dr. Toomey. We're going to do the roll call, but Mr. Walker is going to ask people, since we have some new members, to say about 2 sentences about ourselves as we're introduced. Mr. Walker.
Thank you, Mr. Chairman. First I have on my list is Major General Thomas Carden. Is Mr. Major General in? Okay. Dr. Catherine Cheek.
Present.
Would you say a few words about yourself, please?
Good morning. I'm sorry, I was trying to get organized, and it's good to see you. And you need me to say a few words about myself?
Yes. Chairman Curran asked everybody to say a few words about themselves because there's some new people here.
Oh, okay. I'm Dr. Catherine Cheek. I'm a pediatrician. I worked and lived in Columbus, Georgia for about 37 years. I'm currently retired since January. Still doing a lot of pediatric work and consulting. I'm on the state medical board, and I've really enjoyed working on the public health board for, gosh, greater than 10 years. And trying to think of anything else. I have 3 grandchildren and said more than anything, have just really enjoyed working with public health and the department and all the very talented people that work there. So thank you so much.
Okay, thank you. Dr. and Chairman Curran.
Hi, thank you, Mr. Walker. I'm Jim Curran. I'm formerly Dean of the Rollins School of Public Health at Emory, now just a professor who has no power or influence or money or space. But I'm board for several. Enjoyed working with all of you and trying to do the best we can to help Georgia stay healthy.
Thank you. Next I have on my list is Gregory Lane, but I just saw an email where he said he did not have a link to join the meeting. Mr. Lang, are you on?
I'm in the meeting now, sir.
Okay. Welcome, Mr. Lang. Would you say a few words about yourself, please?
Greg Lang, the 12-year executive director of the Good Samaritan Health Center in Gwinnett, 40-year career in healthcare on all sides of the fence, provider, administrator, technology, managed care, etc. And I'm happy to be here to represent citizens of the greater metro Atlanta area that our charitable clinic serves.
Thank you, sir. Next is Dr. Mercer.
Thank you. I'm Cindy Mercer. I am retired.
Right.
I don't know.
I am retired OBGYN, practiced in Athens, Georgia, 39 and a half years, retired 2 years now. I did high volume OB practice for the last 15 years of my practice, did just GYN surgery. Enjoying my 4 grandsons and still participating in the state OBGYN society. I'm past president of Georgia OBGYN Society, past chair and vice chair of District 4 American College OBGYN, and serve on the MCG Wellstar board, and have enjoyed I'll have to look back as well, 10 to 12 years on the public health as well. So thank you.
Thank you, Dr. Mercer. Dr. Rodriguez. Okay, let's move along to Dr. Shin, Ryan Shin.
Hi everyone, my name is Ryan Shen. I'm an orthopedic surgeon with the Kaiser Permanente. So I've been with the organization for 9 years. I also sit as a chief of orthopedics and physician director for academic affairs. I've been fortunate enough to serve alongside all the board members for past 5 years or so. I can't believe time flew by, but we went through COVID and many different things. So thank you.
Thank you. And Valerie White, Ms. White.
Hello, it's Dr. White. I've been with the board now for 5 years, and my background is in general surgery. And I'm currently now doing administration and supervise several urgent cares, and I'm the medical director at Concentra just outside of Atlanta.
Thank you, Dr. White. And last but not least, I'm Michael Walker. I've been on the board for about, I guess, a year, going into my 2nd year. I'm in the healthcare space. I'm a broker. I'm the national secretary for the National Association of Benefit and Insurance Professionals, and I'm happy to be serving with you guys. That's all I have on my list. Did I miss anyone? Okay.
Thank you.
Dr. Curran, I turn it back over to you.
Thank you, Secretary Walker. Off, I guess, to old business, which is everything that happened before today. Dr. Toomey.
Okay. There's no minutes, eh?
Oh, yeah.
I'm new business, but I think the old business is any minutes that I believe were sent out.
Yes, they were.
Yeah, I think we were asked to approve them electronically. Because I remember doing so, but we could ask the board now if they have any comments on the minutes. And if not, if someone would give a motion to approval.
So move.
Second,
All in favor?
aye.
Looks like we got it. On to Dr. Toomey.
Okay, on to new business. We have I think, a really exciting agenda today, which reflects some of the items in the news. One of the most important things that you probably have been listening about is the avian influenza situation in the US. And I think it's always reassuring to hear from Dr. Drenzik about what we are doing. But to me, the most reassuring thing is to be able to hear about the strong relationship we have with the Department of Agriculture here in our state, which is not reflective of many other states in the country. We have very strong, longstanding relationships with the agricultural community that long predated COVID, but really strengthened during COVID as well. So we'll be talking about that, as well as getting a child health update. And we were talking before the board started about some of the incredible innovations that have happened in child health, including for hearing, child hearing and treatment of hearing disorders. And I know Dr. Mercer has special interest in a lot of these discussions. And I'm really looking forward to hearing more about our update and some of the other things that we have going on. And I'll leave Dr. Rustin to describe what's a very interesting, I think, recruitment video that we've been able to develop that I think will really help better encourage people to come to work in public health at a time that public health may not be the top priority for everyone now graduating all over the country. But I also wanted to just talk about training in general. And certainly Mr. Walker talked about some of this, as did some of the other board members, about here we were through COVID and other things and how much we learned. But one of the interesting things we learned was also that some of our very best staff who were super trained epidemiologists may not have known how to supervise. And we were in a position to be very lucky in a partnership that was partnered with the Rollins School of Public Health with support from the Woodruff Foundation and several other foundations around the state to be able to train young emerging epidemiologists out in our districts as well as in our state office. And yet, as good as our epidemiology team were, they may not have been actually trained how to be mentors. And I don't know about you all, but as a physician, I wasn't necessarily trained to be a mentor or even to, frankly, to be a manager. And I think that's something you can get with time, but also needs some special training. And recognizing this need that we had in the state, Dr. Drenzik and I and several others met with Dr. Chamberlain, Dr. Alperin, an extraordinary woman we call Moose, but her name is Melissa Alperin, at the Rollins School, to put together a streamlined, customized training for mentoring for our epi team. And this is being rolled out next week. We're very excited about it. I believe we're the first in the country to be able to do this. And we hope this will set a tone for how epidemiology teams all over the country can begin to have this kind of development training for their epidemiology staff, as we need to grow our teams, whether to address pandemic influenza or whatever the next situation that we're called to respond to. And I don't think Dr. Curran even knew about this. And this is something we've done quietly, but we're very excited about the rollout coming up. And kudos to everyone, Dr. Drenzik and her team, and Dr. Alfred and their team. And this is a groundbreaking training that we'll be rolling out. Just as we have been we have gotten significant recognition nationwide for our partnership with Rollins and the Woodruff funded partnership. I think this too will also get that kind of attention nationwide, because it was something that we saw was needed. It lit up during COVID and we addressed it. And I think that this is going to be an exciting time for us to grow and learn from this. The other thing that in terms of training, I've talked to some of you, not all of you, and I hope to be able to reach out to the rest of you over the next several weeks. One of the things that came up in discussions is that, you know, we don't really have a board orientation. Frankly, we don't have much of an orientation even for new staff in public health right now. And part of that, I think there had been some, but it was no longer valid given the changes during COVID. And so we are in the process of finalizing a board training, which I think will be terribly exciting for all of us, because it will be an opportunity for us to either introduce for the first time the breadth of the Department of Public Health statewide, which is quite diverse, but also to allow us to hear from you what are the things that are most of interest, and what are some other things you would like to see us working on. So this is a preview of what I hope will be a very soon training program. We will be meeting in person, and I'm not envisioning this as just for new board members. And I'm still considering you, Mr. Walker, Secretary Walker, a new member, but also for members like Dr. Cheek, like Dr. Mercer, who have been here quite some time, but also have a different perspective on how things are. And so stay tuned. We'll be announcing that soon, and I'll be talking with those others of you in the coming weeks. So thanks so much. Looking forward to that. And with that, let me turn it over to the state epidemiologist, Dr. Sherry Drenzick.
Thank you so much, Dr. Toomey. Members of the board, it's a pleasure to be with you. My talk today is entitled Bird Flu. It's not just for birds anymore, and we'll get into that in a second. Next slide, please. So in the short time that we have together, I want to cover really these four main areas. I really want to just kind of set the stage, give you a little bit of background about avian influenza, which has, again, been going on for some time now. I want to talk a little bit about why we, both in public health and the agriculture communities and the agriculture industry, are concerned about bird flu and all of its forms. We'll talk a little bit about the current situation that is ongoing here in the US, which is really very unique, very rare. We haven't seen it, manifest in this way before. And we'll talk about preparedness and response efforts, both at the federal level and here in Georgia as well. And as Dr. Toomey alluded to in her opening remarks, we in Georgia have had a long-standing partnership with our agriculture communities, both at the government level and at the industry level, and have worked on avian influenza preparedness and response for many, many years. And I think we're very experienced and prepared. And as flu is known to do, it can surprise us. But we are ready and we are prepared despite any surprises that come our way. Next slide, please. So I want to really briefly give you an orientation to flu viruses and how they typically behave. First of all, influenza A viruses are traditionally named by two proteins that exist kind of on the outer surface of the virus itself, either H or N, in varying combinations. So when you hear terms like H5N1 as a name for a subtype of influenza A, it's relative to these proteins on their surface. And what's unique about flu is that normally flu subtypes are adapted to and stay within really certain species. They have their own reservoirs, and really there are certain subtypes that essentially stay in those reservoirs. So for example, for humans, our most common flu subtypes are H1 and H3. For example, when you hear about human flu surveillance and seasonal flu surveillance, we talk about H1N1 and H3N2. These are human flu viruses that are adapted to us and are maintained and circulate in people. Birds also have their own type of flu subtypes. They're usually H5s, H7s, and H9s. So these types of flu viruses are maintained and circulate in birds, varying types of birds, but usually bird flu stays in birds, human flu stays in humans, and that's where we want them to stay. However, sometimes when flu viruses replicate themselves, they can acquire mutations or changes or make mistakes in their replication that occasionally allow them to jump species. So for example, a bird flu type like H5N1 can jump into or spill over into a human, causing an infection there. This is not common, but it has occurred. And as a matter of fact, we've been dealing with H5 and other avian flu infections in humans around the world since 1997 commonly. So again, for a number of years, we've been dealing with avian flu that has been, occasionally jumping into people. But what we worry about is that since bird flu typically doesn't belong in humans and it's a brand new virus to us, sometimes these infections can be very severe. So we haven't really been exposed to them before. And what we really don't want to happen is that if the bird flu virus enters a human, acquires even more changes or evolves or changes even further, they may even acquire the ability to go and be transmitted from person to person to person over time. We haven't really seen a lot of that. That's what we don't want to happen. We don't want a novel, brand new flu virus to emerge after sustained spread in people. So this is, again, essentially how flu viruses should behave. Let me set the stage by the next slide and kind of explain this in pictures really briefly. I want to take an example that we've been dealing with here in the US since 2022. So for 2 years now, a very certain type of H5N1 that's called clade 2.3.4.4b up in the corner there, it emerged in wild birds and waterfowl. So as you see the duck here, this particular H5N1 subtype emerged in wild birds. They don't get sick. They carry it, they transmit it, but they don't get sick. And over the last 2 years, we have seen wild birds transmit H5N1 to poultry across the United States. There have been over 1,100 different outbreaks in poultry, both commercial operations, backyard operations. So that's the top. Again, and we've been dealing with this over time, and our poultry industry is well prepared and essentially does a tremendous job of surveillance in birds. And what has occasionally happened and rarely happened is that we actually saw a single human infection from poultry to people with this H5N1. It happened in Colorado a couple of years ago. One person, at least, that was detected. We don't want it to go any further than that. So the poultry spread, we're well versed in that. Occasionally, wild birds also transmit H5N1 to other mammals. Down on the bottom, these are just sporadic infections. There have been a number, over 200 different mammalian infections with H5N1, but they didn't go very far at all. They're really kind of singles. Mink, bear, goat, seals, dolphins, coyotes, a number of kind of one-offs. But again, did not go further than these particular animals, did not get transmitted to people. So let's talk about what we're dealing with now, currently, and that's in the middle. Wild birds ended up transmitting H5N1 to dairy cows on farms. And this has never been documented before and is really very, very new to us. And actually has resulted in another single instance of a human infection from a cow to a person. This person worked on a dairy farm, had very close contact with an infected animal. And again, it has not spread further than that. So again, as we sort of illustrate this in pictures, what we want to prevent are, again, people getting infected with animal viruses and then sustaining that spread and changing the viruses to spread even further. So next slide, please. We'll get into a little more detail. So why do we care? Why? What is the overarching concerns? And I think both of these are very clear from our previous description. There are two main concerns about animal viruses, such as bird flu H5N1, and the first is economic. The first is a strong economic concern for agriculture industries. Again, as far as the poultry outbreaks that have been going on for the last 2 years, there have been over 91 million birds impacted that had to be depopulated. The costs are astronomical. And again, there are economic concerns regarding the perception of food safety. Food is safe, but there's perception about whether, or questions about whether it could be. And again, the prices of food, etc. So that's the economic concern. But for us in public health, and our primary concern is a potential pandemic. So if any animal flu virus, like these bird flu viruses, develop the ability to efficiently infect people, and then they further evolve and spread from person to person, it's possible, not likely, not common, not a run-of-the-mill thing by any stretch of the imagination, is truly the worst case scenario. But a pandemic could occur if a novel flu virus emerged in people after having been infected with animal viruses. So that's why we spend the energy for preparedness and planning and response that we do, is to address these overarching concerns and mitigate spread in animals and mitigate spread from animals to people so that these things don't happen. Next slide, please. So what's going on right now in the US? So it's actually been going on for a few months. The first detection of H5N1 in dairy cattle occurred in late March. And it's now impacted about 40 dairy herds in 9 different states, not here in Georgia. It began in Texas. And we've also seen, as I mentioned before, 1 dairy farm worker that has been infected with H5N1. This worker, again, worked on a dairy farm in Texas, and their primary symptom was severe conjunctivitis. However, as this has been evolving over time, there hasn't been a lot of widespread animal and human testing. So it is likely that the scope of these infections is broader than just these 9 states. The testing initiatives are coming, and I think we'll be able to identify and characterize the magnitude and scope of this current outbreak coming very soon. So when we looked at the question mark, as we're thinking about, well, is this a new type of H5N1? What did our genomic sequencing tell us? Is it already changed, or is it the usual 2.3.4 that we've been seeing for 2 years now in poultry? Well, the good news is that it is the same thing that's been already going around for 2 years. It is the H5N1 clade that we've been seeing for 2 years in poultry. But there have been there's evidence of 2 slight mutations or reassortments since these viruses have infected cattle. So in the cattle, some changes are beginning to occur. Again, we're not seeing widespread cow to human infections yet, but we need to keep an eye on these viruses and how they change. We don't want them to adapt not only strongly to cattle, but then acquire human adaptive mechanisms that it can begin to spread in humans. The other thing about this, as we're kind of thinking about, this probably was going on longer than we knew, because even looking at the genetic sequencing of these cattle viruses, even that we can draw clues about when it began and when it was introduced into these cattle herds in Texas. And it looks to be that it was introduced by wild birds to cows. That part's not a surprise, but in December of 2023. So it's likely been brewing and circulating, a few months longer than we even sort of recognized it. We were really looking for it in cows. And it shows up a little differently in cows, as I'm going to describe to you in the next slide. We haven't seen any human-to-human transmission yet. We have not seen it in beef cattle, only dairy. We have not seen it in swine populations, another good thing. But cats on dairy farms have been infected and impacted. And interestingly, it is thought that they were impacted by consuming raw milk from cows that were infected. And cats displayed their infections with neurologic symptoms, really super different. Every animal that gets infected kind of manifests their flu in a different way, which is quite fascinating. So let's take a look at that. Let's see what the differences are. Next slide, please. Let's take a look at the differences between essentially avian flu in poultry, which we have a lot of experience with, and now in cattle or in dairy herds, which we don't have a lot of experience with. And they're really very different scenarios. So for poultry, as I mentioned, these 1,100 different outbreaks that have been going on in the US for the last 2 years, H5N1 spreads really rapidly in poultry. It makes them very sick. It's rapidly fatal. It's a very severe respiratory infection, and it spreads so quickly that a commercial poultry operation or farm actually depopulates the entire flock of poultry in order to prevent spread. But in cattle, it looks so much different. It's not severe. It's not fatal. They recover in a few weeks. They develop, very slowly appearing symptoms. They kind of go off food, and then they also begin to decrease milk production, and sometimes the milk actually appears different. It can be thicker or it can have a yellow color. And we also believe now that there can be asymptomatic infections in cattle. So they don't show anything at all. And we don't know how or what the role is for those asymptomatic infections in regards to spread and how it's being transmitted. So cattle are not depopulated. The symptoms are relatively mild, but obviously it's a huge economic concern as well because of this milk and the decreased milk production. And again, the need essentially to dispose of milk, that is improper, that may be impacted with viral particles. They're shed in milk at really high levels. So raw milk has and can have live H5N1 virus. And so raw milk is definitely a risk. Pasteurized milk is not. Pasteurization temperatures kills H5N1. And again, we do not expect there to be any live virus in pasteurization. So how do cows transmit kind of one to the other? It's not extremely well characterized yet, but a leading hypothesis may be that even because it's shed at such high levels in the milk, maybe even the milking equipment can transmit the virus because it's raw milk still at this point, right? So it could be transmitted from cow to cow to cow via the equipment. But, there may be some other, sort of natural type of transmission modes as well that are still being studied. Doesn't look to be a respiratory disease at all. So it doesn't look like it's respiratory type droplets, but much more study is needed. So really very different pictures. Let's take a look at the next slide, please. So what is so far in this really unique situation that's been evolving over these few months? What has the response been, again, at the federal level, by the agencies that actually regulate and support the agriculture industry? Well, first of all, the government agency, the federal agency that regulates milk products is FDA. And in order to demonstrate that the commercial milk supply is safe, there have been recent studies done by FDA where they actually looked at a sampling of almost 300 samples of retail milk, commercial milk products that are already in retail stores, and dairy products such as cottage cheese, sour cream, half and half, and they tested them for H5N1. They did not find any live H5N1 virus. And that's good news. What else is going on federally? So initially, these cattle that were infected, it wasn't really clear what was going on in regards to this being bird flu. And they may have, even though their milk production was low or the milk was off a little bit, they were moved maybe from one farm to another. And that's how, again, we ended up with 9 states being impacted initially, is that dairy cattle were being moved from farm to farm. It's typical, it's part of their normal operations as well. But now, as of the end of April, a new USDA order, federal order, again, requires that no dairy cattle can be moved interstate without a negative H5N1 test. And if anybody comes up with a positive H5N1 test in an animal, it's required that be reported to USDA. So again, that was a way to kind of restrict movement of infected animals and impacting other farms. And hopefully will it also encourage more testing as well. However, just as of last Friday, the federal government also announced over $200 million in federal funding to assist really in 2 areas. The first is $100 million in incentives for dairy farmers and farm workers to test more, to encourage more testing of animals and humans, both asymptomatic and symptomatic, as well as cover costs for veterinary care, lost milk production, et cetera. And that's on the USDA side. And on the CDC side, or the HHS side, there's another $100 million that will shore up bird flu surveillance efforts in regards to ensuring that we have adequate molecular sequencing that continues and we can monitor changes in the virus, looking at other surveillance indicators, such as looking at it potentially in wastewater for influenza A. You can't really look specifically for H5N1, but can look for influenza A, and money for public health officials and agencies to monitor or test any exposed farm workers. So these response efforts are beginning in earnest, and hopefully will again have a strong impact in mitigation. Next slide, please. So after all of that story, how much should we really worry? Should we worry about a pandemic? Are we close to having a pandemic? The answer is no. At least we should always be prepared and be aware. But as of this very moment, as regards to the current situational awareness, the human health risk remains low for the general public. Again, we have only documented this one human infection with direct, in a farm worker with direct close exposure to an infected cow. So we really want to ensure that the highest risk population right now seems to be dairy farm workers, We want to ensure that they're aware that they have adequate protective equipment if needed. And there are a number of federal initiatives in sort of looking at provision of personal protective equipment and education for dairy farm workers as well. What we really worry about is this, again, sustained human spread, that it gets in one person, changes and goes from person to person to person. We have not seen that. We have not seen that yet, but we still need, that's why it's so important that we have ongoing testing of animals, testing of people that are potentially exposed, and having adequate genomic sequencing infrastructure to monitor changes in this virus. So even though we really shouldn't necessarily worry greatly, it's always prudent to prepare and plan. So let's talk in the next slide just a little bit about how we've been doing that here in Georgia. For us in Georgia, we have been working on avian influenza preparedness and response for many, many years, well before even the emergence of the 2022 version of bird flu. We've been working on it with our agriculture partners for more than a decade. We have strong relationships and partnerships and protocols and plans in place with the partners that are listed here, such as, of course, us and DPH, but the Georgia Poultry Laboratory Network, state and federal agriculture, and other state agencies, industry here in Georgia, the University of Georgia, and the laboratories as well. So again, this planning has taken place. We have a strong surveillance infrastructure in place, both in the animal realm and also in people. This was primarily focused on poultry to begin with. We don't have a tremendous number of dairy farms in Georgia, but we do have some. But again, we will, in concert with federal animal surveillance, we will be communicating with USDA as far as and other agencies in our state Department of Agriculture in regards to animal surveillance. But our primary role at DPH, the public health role, is primarily to monitor persons or workers that have been potentially exposed to avian influenza, either in poultry or in dairy herds. And we have a system in place that we've used for a variety of monitoring responses for a number of infectious diseases. We have an electronic system, and we would enroll workers into an electronic system where we can contact them every day, monitor them for symptoms of flu, and provide testing at our Georgia Public Health Laboratory for H5N1 flu if need be and as appropriate. Next slide, please. We actually are very experienced in this area. We've done a lot of it well before 2022, but in this current outbreak among poultry, over in 2022, we in Georgia documented 2 H5N1 outbreaks. Both of them were in backyard poultry flocks, and we monitored 117 exposed persons. Many of them were responders. Some were farm workers, and some were Department of Agriculture employees that worked on farms and worked in depopulation of these flocks. And we actually had a couple of people that developed some respiratory symptoms during the time of their monitoring. And we were able to provide a telemedicine consult, collect specimens for testing at the Georgia Public Health Laboratory, and they were negative for flu, or any flu, H5N1 and any other flu. They were actually positive for rhinovirus, so they had another respiratory infection. But we were very grateful that we had the ability to monitor them and keep an eye on, because we don't want, kind of, again, these human infections to sort of go unnoticed, spread to other people, and potentially change the virus. Next slide, please. So all in all, as you heard this really fascinating story, really the bottom line for us is that as is true of most everything I talked to you about, epidemiology and surveillance, including genomic surveillance, are really the foundation for how we decide the most appropriate and scientifically founded prevention and control recommendations. But the good news for us in Georgia is that we have very strong existing partnerships and plans with the Department of Agriculture and our other ag partners. I feel very confident that again, we're very ready to face whatever comes our way. And that is the beauty of this type of preparedness as well, is that even if this bird flu situation does not worsen, if it fizzles out, if it doesn't go anywhere further, no matter which way it goes, this type of preparedness has overarching benefits for everything that we do, including sort of routine seasonal flu preparedness, pandemic preparedness, and response really to any emerging infectious disease, which we've had our share of. So all of these partnerships and initiatives and surveillance mechanisms are a strong foundation for no matter what we face in the future. And I hope we don't have to, but I'll stop there. And I think that is it for me. Thanks so much. I'm happy to take questions if we have time now, or we can save them for later, whatever is easiest.
Thank you, Dr. Dranzik. Very thorough, and I'm glad you're here and can tell us all about this. Are there any comments or questions for Dr. Dranzik? Please raise your hands. It was very clear, I guess, Sherry.
All right.
Dr. Curran, I was going to say, when Sherry and I think, gosh, it was years ago we first talked about this. I didn't understand what happened when you identified these flocks of chickens that were infected, and depopulated is a very nice euphemism. When I realized the really hundreds, thousands, millions of animals that have died because of this culling process, it's really quite even more important that we understand kind of the implications of this. I mean, I'm sure there's a reason for not saying we have to, kill these birds, but that's the truth. That there's no other way to do it, and you're not going to depopulate, cows. But fortunately, they have a different natural history. And the other question I had for you were beef cattle. Do they carry this as well?
So it has not been ever documented in beef cattle at all, and they're testing them now. So I see no reason why it couldn't happen, honestly, because there have been so many other sort of mammals that can, but at least we haven't seen it, and they're monitoring it very well, and they have their own, sort of movement restrictions and requirements too. So yeah. Or we don't want it to end up again as in pigs.
Yeah, it's really interesting. And again, I'm just so grateful that you and your team, my team and I have great relationships with the Department of Agriculture, and we'll continue to work with them.
Thank you all. I appreciate it.
Well, congratulations, and also congratulations again, Dr. Toomey, for the training initiative, which is commencing. Dr. Morris.
Hello, everybody. Good afternoon. Thank you all for having me and allowing me to give some updates on some of our the Office of Child Health programs. Have plenty of projects and quality initiatives going on, but today I'm going to highlight one in particular. Next slide, please. So this is our otoacoustic emission hearing screening initiative. From here on out, I will call it OAE. It will be a little bit easier to follow along. So our OAE hearing screening initiative, this was made possible by some COVID relief CDC funding that DPH received. And the goal of this funding was to provide additional resources for hearing screenings for school-aged children. during the COVID times, there's a lot of services that were unavailable. And so this is one way that we wanted to kind of fill that gap. And then there are plenty of other benefits that kind of come along with this. And one of them that I'm going to talk about is this basically reducing this bottleneck into some of our early intervention programs. So our goal with this initiative is to improve access to on-time intervention services. So thinking about, autism-related services or speech language therapy, and to promote age-appropriate language and literacy for children in Georgia. So we received this funding from the CDC, and then we at DPH at the state level then dispersed this funding to all 18 health districts to purchase their own hearing screening devices. And the reason why that's so important is there are a lot of areas of the state that don't have pediatric audiologists. And so many of these services that I mentioned, the intervention services, they require that a child either pass a hearing screening, or if they have a diagnosed hearing loss, that they have the appropriate amplification or intervention before they can have certain evaluations. So for some areas, especially rural parts of the state, if they don't have access to that hearing screening, then they may not have access to these other really time-sensitive services. So that's kind of one piece. One kind of added bonus was this younger population, this 2 to 3 age range of hearing screening. And then the other part is for the school age population. So the incidence of hearing loss, it increases in childhood. So it goes from approximately 1.7, that's anywhere from like 1 to 3 out of every 1,000 infants at birth are born with a hearing loss, up to about 5 in every 1,000 ages 3 to 17. And so in Georgia, we have the newborn hearing screening. Every infant gets their hearing screened at birth. And then the next screening that really is required is for children who are entering public school system through the 3300 form that screens for dental, nutrition, vision, hearing. But there's really no other mandated hearing screenings kind of between those different ages. Next slide, please. So what are OAEs? So if you think of hearing screenings, I'm sure everybody here is aware of you hear the beep, you raise your hand. So that's called a pure tone hearing screening. That's the gold standard. That's, the best case scenario. And that's the test that you really want to use for these children who are developmentally able to raise their hand when they hear the beep. But for many children, especially in this like age, anywhere from 6 months to actually birth to around 3 or 4, those children cannot raise their hands. And so luckily we have another test called OAEs, which is an objective measurement of the inner ear or the outer hair cells inside the cochlea. And so it doesn't require the child to do anything. It's really quick if they're quiet and still, and it takes about 30 to 60 seconds per ear. And this equipment, when it's a screening piece of equipment, it just gives you the answer. Did the child pass it or did they fail it? There's no interpretation needed. But prior to 2022, Georgia had a very unique law that basically prohibited anyone other than a physician or an audiologist to complete OAE screening. So every other state, anybody can do OAE screening if they've been trained, but in Georgia, nobody was allowed to do it unless you were a physician or an audiologist. But in 2022, that law changed and it opened it up to allow anybody who has been trained by a Georgia licensed audiologist to complete OAE screening. So this OAE hearing screening initiative is kind of coming from that law change, because there was this chance to expand access to hearing screening in underserved areas. Next slide, please. So I'm really proud of my team who did this, and I'm going to say we, even though it was mostly them. But we have a child health audiologist here at DPH, and her name is Suzanne Carruthers. And so in that last slide, I mentioned that you have to be trained by a Georgia licensed audiologist. There are free, well, actually, I don't even think there are free online training courses. There is one that's a national training course. You have to pay for it, but it would not be by a Georgia licensed audiologist. So we got together with our colleagues at Georgia Department of Education, because this project is going to impact school age children, so it's going to impact our partners at DOE, and we got a group of subject matter experts of pediatric audiologists, and they created an online training module. that is free, and it launched about 2 weeks ago. And so this is now accessible pretty much to anyone in the country who can now complete this online hearing screening training. And what's really kind of exciting about this project is just this cohesion between DPH and Department of Ed, between the public health nurses that from our standpoint will be doing a lot of these hearing screenings, and also those school nurses. So we developed the training that would be applicable to both audiences, whether it was a school nurse completing the training or a public health nurse completing the training. We have one developed testing protocol for both audiences, as well as one kind of uniform screening form, so that there's just a little bit more consistency and less room for error. And what DPH will be doing, because it's the hearing screening training that's online, it's about 90 minutes. It gives a lot of the foundational information about the hearing screening. But we are also, for our DPH nurses, we want them to be as confident as possible. So our child health audiologist, Suzanne Carruthers, is doing hands-on competencies kind of as this big like onboarding process for these nurses around the state. So these district staff will complete the online training module first, and then they'll get their hands-on competency check off. So in April, we were in Lake Lanier, and we trained, I was there, so I can say we trained over 40 individuals from every single health district was represented. And then between May and June, they have 220 individuals signed up, and these individuals are all district staff. So public health nurses for the most part, as well as other staff that they've chosen to be trained. And so they will all receive their certification. And then Suzanne and I we will be presenting at the Babies Can't Wait conference that's in June. And we're going to be, it's a 2-part presentation. So we'll present and then we'll do their hands-on competency. And our goal there is that these Babies Can't Wait providers then could offer the hearing screenings for their children who are waiting for services or waiting for that evaluation to try and kind of streamline that entry into early intervention. Next slide, please. Okay, and now switching gears, kind of, just a brief update about CCMV. This is an exciting one. So we approached Babies Can't Wait, and we basically made the request, could CCMV, congenital cytomegalovirus, be added as a Category 1 condition, which basically automatically qualifies those children for services through Babies Can't Wait. And so their Category 1 work group, who's made up of Babies Can't Wait state staff, district staff, as well as medical physicians, they unanimously said yes. So now, effective, honestly, probably a week ago, any baby who tests positive for CCMV will automatically qualify for Babies Can't Wait. And this is a big deal. It's even those babies before hearing targeted CCMV rolls out, those babies, even if they pass their hearing screening, they are still at a significantly higher risk of developmental delay. And so they will automatically get that extra early intervention from early on. Next slide, please. Okay. I will share just a couple other updates about CMV. We have a stakeholders group of about 25 physicians that convened starting in January. And these are specialists from across the state. We have neonatologists, infectious disease physicians, MBs are on there. We have pediatricians, like the list goes on, ENTs, audiologists. And so they have been very generous with their time, and we are developing the CCMV policy and procedure manual so that when and if this does go into effect, every hospital and pediatrician or primary medical home will have access to like exactly what they need to do and what that protocol is. And so I'm very grateful for that group. And they also put kind of the finishing touches on the edits, the proposed language, and that was submitted just last month to our government affairs office. So they're just pulling things together, and it should be going for public comment here in the coming weeks. Does anyone have any questions?
No questions, but I'm sure Dr. Mercer and myself both say thank you and bravo, and we're looking forward to it. And y'all have done lots of
groundwork to make it happen, but this is awesome for the babies in Georgia. So thank you.
You.
Yes, thank you, Melanie. This is exciting, and all this extended training is just very exciting, and it's so good to be at the grassroots of this. This is not a setup question. I really don't know the answer. I don't, so that's not my area of expertise, but can you explain the difference in the OAE and then the ABR?
Yes. So that's a great question. So OAE, so otoacoustic emission, and then ABR is auditory brainstem response test, just for everybody. So those are two types of tests that are primarily used for infants. So when we think of the newborn hearing screening, we have two ways of screening their hearing. One is via OAEs and one is ABR. The OAEs test the function up to the level of the cochlea. So it does not test the nerve and above. It tells us nothing about how that brain or how that sound makes it all the way to the brain. Whereas the auditory brainstem response test is a more thorough evaluation. And it sends a signal and basically sends it through the cochlea to the nerve up to the brainstem, and we look for a response there. For infants, you can use either one, but if a baby has spent any time in the NICU or 5 days or more in the NICU, they have to have an ABR because they are at risk of having a condition where their cochlea works, but their nerve is not firing synchronously. It's called auditory neuropathy spectrum disorder. So to keep it simple, ABR is the gold standard for infants, but you can't really you have to be completely asleep. So like adults can't, you have to be sedated. If somebody was going to do an ABR on me, I would have to be put under medication and put to sleep to do it. Whereas they could just run OAEs on me real quick for a quick screening. So they're both, they tell us a little bit different things, but for infants, the ABR is the gold standard.
Thank you. So the OAE should have the sensitivity to pick up the congenital CMV babies.
Yes, it should. And actually for, if we're thinking about for infants, yes. So it actually has a higher fail rate than ABR, not necessarily for picking up more hearing loss necessarily, but more because it's really sensitive to vernix and the ear canal and things like that. So from my perspective, I think hospitals would probably be better off using the ABR because they're going to catch the right kids, more quickly. But they have in Georgia, they can use either one as long as they did not spend time in the NICU. Did that answer your question?
Yes, thank you. I'm just going to give a little brief. I'm so interested in this hearing disorder. I'm just going to give an overview to the board. Because I'm like a dog with a bone on this issue, because my grandson 5 years ago was born with congenital CMV from a normal asymptomatic normal pregnancy and delivery, failed the newborn screening test. And it was only because of our ability to interface medical care and aggressive management did we receive a very early diagnosis, early intervention, the controversy of antivirals, but used antivirals. And with the grace of God and medical intervention, we have a normal 5-year-old that has bilateral cochlear implants who is mainstreamed in kindergarten now. But in doing that, I became so sensitive to how the normal population could not do this. And so that is my thrust, is because I want everybody to have that aggressive management, and we're moving toward that. Thank you. Thank you.
Yes, no, thank you for sharing your story. There's a whole other quality initiative project going on for kind of hospital level and kind of how to talk with families when a child does fail the hearing screening, and then really improving reporting. So because we need to know at the state when a baby fails so that we can provide that like intensive intervention. So we hope to see some improvements.
I think we will.
Okay, well, thank you.
Horace, that's incredible progress on those two topics, and thanks also to the encouragement of Doctors Mercer and Sheik and their advocacy. So that's great. Dr. Rustin.
Yes, so thank you, everyone, for letting me speak briefly. As the last board meeting, we presented to you some work on our Women's, Infants, and Children campaign. So for this meeting, we wanted to present our HR recruitment campaign. As Dr. Toomey had mentioned early in the meeting, we want to recruit, retain, attract the best talent that's out there, but for them to be able to do that, they need to know about our profession and know about the important work that we do in public health. And so as we partnered with our contractor EY on the WIC campaign, we also partnered with them along with our HR department on developing this recruitment campaign. So I'm going to turn it over to Joel Frashone with EY. I believe Joel's on the call, and have him present the work that they've been doing and a short video that was created that I think is fantastic. Joel?
Well, thank you, Dr. Rustin. Dr. Toomey, good to see you again, Commissioner. Good afternoon, everyone. Yes, I'm Joel Frashone. I oversee our day-to-day operations with DPH, and I'm joined by my colleague, Cora Curio. We're both with EY, and our team works closely with Nancy Neidham's team and others in the department on a host of communications and other works, including HR and WIC, like Dr. Rustin mentioned. He also mentioned our colleagues Siobhan Williams and Hannah Welsh had the honor of presenting our WIC work to the board 2 months ago, and we're happy to be back here. So thank you for the opportunity to present the latest that has gone into and what is now coming out of the DPH We Protect Lives campaign, which is a key component of the department's recruitment and retention efforts. We couldn't be more in sync with Dr. Toomey, Dr. Rustin, and the HR team on attracting the best talent to DPH. So today we want to share with you some of the best practices and thinking that went into developing the campaign, why DPH employees are the stars, some national trends and market catalysts, and where the public will see the campaign's videos, billboards, social media posts, and more in the weeks and months to come. I'll now hand it over to Cora. If we can go to the next slide, please. Cora.
Great. Thanks so much, Joel. And it's really good to be here with you all today. We sincerely appreciate this opportunity to share with you something that DPH has been working really hard on, which is the We Protect Lives campaign, as you can see here. This campaign was designed in partnership with Nancy, Frederick, the communications team. We also worked with the Division of Workforce Management and HR to ultimately promote a consistent message that improves recruitment and public perception. So the campaign is based on conversations that we had with DPH employees. So we conducted a number of focus groups. We had we conducted some interviews across DPH. And basically what came out of those discussions was this very resounding message of we protect lives. So we thought, who better to demonstrate this message than real DPH employees, which Joel alluded to. So the message, we protect lives, as I'm sure you all are very familiar with, highlights DPH employees' commitment to the mission and the impact of a career across all positions, all districts, and at the state level as well. And DPH employees, we found, really do protect lives every day, no matter the role or no matter the location of their work. So Joel and I will discuss this more throughout the presentation, and you will also see some pictures we included in the presentation, like the ones shown here. I know they're probably small, but we'll touch on that in a few slides as well. Next slide, please. Okay, great. So before we dive into showing you the campaign materials, which we're really excited to show you, I want to touch on the value that this campaign brings. So we've already talked a little bit about it, but based on our experience working with public health agencies in other states and our understanding of Georgia and the relationship we have built working with Georgia or working with DPH, we know the impact that investing in public health perception can have. So there are many reasons why public health perception is important. Ultimately, it increases trust. It leads to better health outcomes. When it's a focus, we can recruit and retain the right talent. And we also know, as I'm sure this group is very well aware, that there are many challenges outside of DPH's control that surround how public health is viewed. So some of these have emerged over the last couple of years. The fact that the world is just full of information overload, there's mistrust, health threats are constantly evolving, and DPH is always having to respond. And resources are limited, it seems like always. So the campaign is really DPH's strategy to help tackle some of these challenges. It's meant to improve public health perception and ultimately support recruitment. And at its core is the experience of real public health employees advocating for the impact you can make through a career at DPH. And this approach is really intended to be inspirational to individuals, prompt them to consider a career in public health, to apply for open positions. And the ability to fill those open positions is absolutely critical to delivering DPH's mission. So successfully recruiting suitable candidates for these important positions is central to the delivery of public health services. And simply said, having the right talent directly impacts public health outcomes, which is why we, feel so passionate about the campaign. Next slide, please. Okay, so now before I turn it over to Joel, I just want to quickly highlight the employer brand that we incorporated into every aspect of the campaign. In some areas, it's more subtle. In others, it's more overt. But we know that employer brand, like we all know, is important for recruitment because LinkedIn research tells us that 75% of job seekers consider an employer's brand before they even apply for a job. And according to Glassdoor, 94% of candidates are more likely to apply for a job if a company is actively managing its employer brand online. So, like I said, we had these great conversations with DPH employees. We understood what they liked about working at DPH and the impact they're having every day at work. And this led to the development of the employer brand that you see here. And just want to mention one really cool thing. This employer brand was also validated with pretty much every employee we spoke to when we traveled across Georgia, collecting materials for the recruitment campaign. So I found it personally touching, and I know the team did as well, that every employee that we spoke to was so passionate about the work they did. They really felt immense pride in the organization that they worked for, and they made an impact every day, no matter what they did. So I'm now going to pass it back to Joel, and he's going to talk about some of the materials we developed and where DPH is currently using them.
Thanks, Cora. And we really did see that. We saw it in every stop across the state. We've one more slide to cover before showing you the videos. So next slide, thank you. So laid out here are the main blocks of work that encompass how we developed and are implementing the overall We Protect Lives campaign. Again, we work closely with Nancy and her team to develop the strategy, which incorporates and addresses all that Cora discussed and more. In coordination with Nancy and DPH public information officers in target districts, we worked out how to be in multiple locations in different cities and towns across the state, who and what to film, interview questions to ask, story ideas and how to bring them to life, and more. Incidentally, our planning was down to the minute, and we even had to forego stopping for peach cobbler when driving from Columbus to Savannah. I still regret that, but we'll be back to take care of that for sure. So over the course of that week in February, we interviewed on camera and photographed specific DPH employees at work across the state. I mean, they were in their natural environment, and it was really energetic to see. Right now, we're straddling the post-production, and DPH has initiated the distribution plan. So 5 of the 9 videos are complete. One is already on YouTube. Several are being folded into media buys. Others will appear at universities and on LinkedIn. One will be part of the new DPH employee onboarding sessions, and so on. And many of the photos we captured are also now in public in different forms. And the distribution plan, this one covers the summer months and beyond. So there's a lot still to do. Okay, next slide, please. So here is the We Protect Lives Everyday impact. It's the long version. It's 1 minute and 47 seconds long. We also have a short version, 30 seconds. And we're going to let the video speak for itself. So if you could play it, please, Frederick.
I would describe DPH as being fulfilling. I feel like I'm actually making an impact on my community.
We want the community to know that we're here for them. We want to make sure that they stay healthy and trust us so we can be their care provider long term.
Having the stability of this job, having the sense of community, having purpose, it drove me to stay here.
I see the impact that I make every day. I feel that being with the Georgia Department of Public Health, I was put here for a reason.
It's a privilege to be able to do the work that I get to do, helping people get into care and live healthy, long lives. One of the instances that stands out in my mind, I was walking down the street, very healthy individual came running up, and when I looked them in the eyes, I realized she was thriving. And that kind of instance is very profound.
I am a person of service. I feel inclined to always be a voice for those that need to be heard, whether it be staff or the communities in which we serve.
The reason I've been at Georgia Department of Public Health for more than 10 years is the community. I have amazing mentors, colleagues. They've invested in my career. They've supported me to be able to do what I love and protect Georgia citizens at the same time.
I'm Danielle Saunders.
I'm Frank Robinson.
I'm Lauren Griffin. I'm Lainey Griffin.
Yo soy Emilio Rodriguez.
I'm a county nurse manager,
risk communicator,
Pediatric nurse practitioner,
communicable disease specialist.
I'm with the Georgia Department of Public Health, and I protect lives.
I protect lives.
I protect lives.
We protect lives.
So there's that, right? It's a really powerful, and we, you don't put words in people's mouths, right? When you do these interviews, they speak from the heart, and they really did here. So the next one is we also created a series of We Protect Lives testimonial videos that also feature DPH employees. We've completed 6 to date. I'm sorry, we completed 3 to date. There's 6 all in total. One is with Eric Jens. One is with Dr. Imelda Feldposh. One is with Jimmy Jones, a truly inspirational nurse, manager, and lovely person in Dalton. And we'd like to show you Amanda's video. So if we could play that one, please.
The reason I've been at Georgia Department of Public Health for more than 10 years is the community. I have amazing mentors, colleagues. The department has invested in me just as much as I've invested in them. They've supported me in my career growth. They've supported creativity. The state health department is the perfect fit because you get to engage with a specific community. And that's what I'm looking to do, is to serve Georgia for the rest of my career. I'm Dr. Amanda Feldposh with the Georgia Department of Public Health, and we protect lives.
Yeah, again, really love that one too. So if we go to the next slide, thank you. So as Cora mentioned, and you've seen videos, a major part of the campaign, without a doubt, we shot approximately 40 hours of footage. The campaign does, however, include a lot of photos. It's multi-dimensional. We collected more than 2,200 of those. Some of those photos are currently in social media posts. Others are on billboards throughout the state. Some are displayed on public transportation. The MARTA campaign, bottom right there, runs through the end of June. So these are a sampling of what's currently in public. We've seen some of them when we're there in Atlanta and elsewhere in the state. Maybe you have too, and we're really proud of that work. All these videos and photos will live in the DPH studio at headquarters to utilize over time. And we intentionally captured much, much more, excuse me, than can be currently used. And the ROI is substantial when using this model, meaning capturing assets for current and future use, producing materials according to the current plan and need, monitoring market trends for catalysts that may require introduction of new different photos, new social media posts, DPH's role in pool inspection to let everyone know they're open and safe for the summer is an example of that. or a recruitment video that's needed to fill a specific position. So Cora has one more slide, and we're happy to take any questions on the other side. Cora?
Yeah, great. Thanks, Joel. I'll just close by sharing with you all that the team is doing a lot of work, like Joel said, to socialize the campaign, not only at the state level, but also to support the districts, since they were such a huge part of making this campaign successful. At the state level, like Joel mentioned, the video is actually live on YouTube, so we really encourage folks to go take a look and share with others. The video is going to be broadcasted on the website. It will be shared on social media channels and LinkedIn. The communications team also had a really great idea to share it during new employee onboarding to boost engagement and really integrate folks into the culture. And then at the district level, we have a toolkit we developed that we'll be sharing with districts. We will be doing a workshop with the PIOs, and we have communication sharing templates so that employees can leverage or share the video through their own networks. And the way the team is socializing the campaign is very intentional. It's to promote brand consistency across the state and the district level in terms of recruitment. And this was a really big goal of the campaign. This strengthens the message majorly. So that is all we have for you today. We really appreciate everyone's time. Again, just really proud of the team that put so much work into this. I really believe that it will have a huge impact across Georgia. And we are happy to answer any questions, however we want to do that.
I'd like to begin in congratulating you. This is really terrific, and it's so very important. It not only should help with recruiting, but and retention, but also with morale among the people who already work there. And in a sense, it could help with branding of what public health is. So many years at the CDC, when people used to think it was very important, and they were so thankful that they weren't part of government. Unfortunately, with COVID, they learned that they were protected by government, and public health has taken a hit, along with any other institution in this we don't trust anyone era that we live in. But I think that the idea that the messages, what people actually do, and what impact they have, can make it look like some of the most promising, interesting jobs available in Georgia. And I'm just wondering if you couldn't combine it with kind of a branding campaign for public health, in a sense that, you know, the people themselves and what they do and who they do it with are really advertisements for the department, but they're also advertisements for people who would like to be able to have that kind of impact. Because people don't understand what public health is. But then when they see people doing it, they say, oh my God, that looks like it's really rewarding.
Yeah, Doctor, I couldn't agree more with you. And, you know, that's the piece that's fun about this, is that they are your brand. Your employees are your brand. And be it an epidemiologist, be it an environmental health worker, there are cool jobs to be had at DPH in government. And I think showing the employees in their natural habitat, if you will, doing their jobs and that they're happy about it. You know, some of the branding, some like to do really heavy, DPH everywhere, whatever your brand is. That wasn't the feel here, but the brand is wrapped in there for sure. And some of our other materials that we're coming out with, it's a little more overt, but your employees are certainly your brand. And there are pieces of this that will shine through as well as we go through it. Yes, Cora, you work on this every day.
Yeah, I was just actually going to add one thing, because that's it was very well said from both of you, but part of the social media campaign, so I know we showed the videos and then Joel touched slightly on the social campaign and some of the media buys, is this We Protect Georgia series, which highlights you know, a variety of programs. For example, I heard earlier in the call about the hearing screening program. We have one that is We Protect Georgia Babies and talks about the program and talks about those who work in the public health lab. And so it's kind of a dual purpose, like it shares about the program, but then it also is like, you could work in this role too. Did you know this exists? So just wanted to highlight that, but it's such a good point.
So the Association of Schools of Public Health have hired branding campaigns, and they have, you know, We Are Public Health and public health buttons and things like this that they give out. But the one thing that occurred to me is that government is rife with acronyms, and the public not only doesn't understand them, but they don't think they really like them either. So, you know, if you could change DPH to Georgia Public Health or DPH to Public Health Georgia or something like that, and avoid using the acronym, it might stick with people. You know, I work for Public Health Georgia. You know, I work for Georgia Public Health, whatever. But DPH sounds too bureaucratic. We love it, but it's bureaucratic. Are there any other comments or questions?
I would just like to make a comment that I thought all the presentations were very informative today and very well done. And in particular, the Department of Public Health, or Georgia Public Health, as Dr. Curran says, I think your presentation is top notch. I certainly enjoyed it.
Thank you, Michael. And thank you, Joel and Cora. Do you have any, does the board have any more comments before we end the meeting?
Dr. Curran, before we end the meeting, I'd just like to make a note for the minutes that Dr. Rodriguez is present. He was available. He was just having technical difficulties and we were unable to hear him. So I just wanted noted in the record of the minutes that he was present.
I can see him from here.
Thank you.
Are there any other comments? Well, we see that the next board meeting is on June 11th. And Kathleen, is that going to be in person or on Zoom?
Well, actually, we were planning to get together and talk about the training. So I didn't know that slide was in there. It's not in my packet. So stay tuned. I want to finish my discussions with some of you individually. Then when we put together that packet or that training program, we'll roll that out. I think the next big kind of formal board meeting is going to be in July, which will include kind of a legislative update. By that time, some of you may know, the governor just finished signing bills. So we're still trying to figure out the full implication and how we're going to implement those. It's going to take us until that time to actually get our implementation plans in place, as well as some other things that we are working on. But between now and then, I'd like to finalize our plans for the training. And so please stay tuned and I will be in touch. But again, the formal board meeting will be in July, and more on that.
So thank you, Dr. Toomey. We have a motion to adjourn.
So move.
Second.
All in favor?
Aye.
Aye.
We'll see you guys whenever the training occurs.
Have a good day.
Have a good day.
Bye.
Bye-bye.